Good evening, everybody. And can I start?
Oh, yes, sir. Yes, sir. You can.
Good evening, everybody. I take immense pleasure in introducing all of you Dr. Dan Gold. He's an associate professor of neurology, ophthalmology, head and neck surgery, and medicine in the John Hopkins School of Medicine. Hello.
Yes, sir.
Can I go ahead?
Hello.
Yeah, and
Okay.
he has got a novel collection of neuro-ophthalmology, which is fascinating. And over to you, Dr. Dan Gold.
Great. Thanks so much for having me virtually. Very excited to be able to give a talk, some education in this new world that we're now living in. So I'm going to stop the video of me just so it doesn't take away from the videos or hide anything on my screen. I'm going to do this in sort of two parts. The first is how to examine the ocular motor system, and then we're going to talk about the vestibular system. So an outline. So for this, how do I examine the ocular motor system to diagnose and to localize a peripheral or central vestibular disorder? So if we're talking about a central vestibular disorder, there's so much overlap in the brainstem and the cerebellum between the central vestibular pathways and the ocular motor pathways, the eye movement pathways, that almost always, if somebody has a central localization of their vestibular problem, their dizziness, their imbalance is central and vestibular, there's some ocular motor eye movement abnormality. So that's why we should care about a thorough evaluation of the ocular motor system. So how do you examine the ocular motor system? So there are lots of important structures in the brainstem, in the cerebellum. In order to generate saccades, the burst neurons, we have to think about, for vertical and torsional saccades, the rostral interstitial medial longitudinal fasciculus, which is in the midbrain. And can you see my pointer?
Yeah.
Yes, okay. So the RIMLF in the midbrain, that's what generates the vertical torsional saccades. In the pons, for horizontal saccades, the horizontal burst neurons are the PPRF, the paramedian pontine reticular formation. If we're talking about gaze holding for vertical torsional, we're talking about the interstitial nucleus of Cajal in the midbrain. If we're talking about simply the horizontal gaze holding, we're talking about the NPH, the nucleus prepositus hypoglossi in the medial vestibular nucleus complex. That being said, the flocculus, paraflocculus are going to enhance gaze holding of these structures. So the flocculus, again, one of their big purposes is to enhance gaze holding, responsible for smooth pursuit pathways, also inhibition of the anterior canal pathways, so that if you have too much activity of the anterior canal pathways because the flocculus isn't working, that's one of the most popular theories for why patients can have spontaneous downbeat nystagmus. What about the vestigial nucleus? Now we're talking about saccade accuracy and the ocular motor vermis, which connects to the brainstem as well. All of these pathways are sort of interconnected, brainstem, cerebellum. These structures are good to know about because you can basically interrogate all of them at the bedside. And in doing so, you can localize the problem to a specific part of the brainstem, to a very specific nucleus located in the cerebellum, for instance. The nodulus, now we're talking about velocity storage and vestibulo-ocular reflex adaptation. So what does the bedside evaluation of the ocular motor system consist of? So we care about the range of eye movements. We care about the ability for the patient to fixate or hold gaze in an eccentric position. Saccades, smooth pursuit, vestibulo-ocular reflex suppression, convergence, optokinetic nystagmus, which we're going to tackle one by one. So how do you evaluate the range of eye movements? So you want the patient to look as far up and down and left and right as they can. At the same time, you want to evaluate their ability to simply fixate on a small target that's right in front of them. Additionally, you want to hold a target out laterally and vertically to make sure that the patient can hold their gaze on the target. This is a normal example. This is what everybody should be doing to assess the range of eye movements as well as the ability to fixate and hold gaze. So make sure the eyes are steady. This is a patient who clearly has an abnormal range of movements. I'm asking her to lift her eyelids, which is a big clue as to the etiology. This is a patient with myasthenia gravis. I'm asking her to make rapid saccades horizontally and now vertically. And you see that the range is very limited. Now you see I'm asking her to do it again, and they're much slower. They have fatigued. They're much slower than they were when I first asked her to. So when we're dealing with a decreased abnormal range, ophthalmoparesis, ophthalmoplegia, this could be supranuclear. This could be progressive supranuclear palsy, where the VOR, the vestibular-ocular reflex, might overcome a vertical gaze paresis. This could be nuclear. You could have a stroke involving the third nucleus or the sixth nucleus. This could be hitting the fascicle of 3 or 6 or 4. This could be the peripheral nerve on the subarachnoid space due to meningitis or intracranial pressure. This could be neuromuscular, as it was in this patient, or it could be myopathic, that is affecting the extraocular muscles themselves. These are examples of abnormal fixation. So you're asking the patient to look at a fixed target, and this is nystagmus. This patient has jerk nystagmus. In this situation, she had hyperemesis gravidarum, which led to thiamine deficiency, which led to Wernicke's encephalopathy, and spontaneous upbeat nystagmus is a common ocular motor feature. This is jerk nystagmus because there's a fast phase followed by a slow phase, fast phase, slow phase. I'm sorry, slow phase, fast phase. This is jerk nystagmus, alternating slow and fast phases. For nystagmus, the slow phase is the culprit. This is another example of nystagmus, but here, the slow phase is still the culprit, but it's just back to back to back slow phases that gives it a pendular waveform. You can clearly see the difference here between jerk nystagmus and pendular nystagmus. This patient has saccadic intrusions where the culprit is the saccade, not the slow phase. This patient has an acute HIV infection that caused opsoclonus. You can see there's no clear slow phase and fast phase. This is not pendular. These are very, very rapid back-to-back-to-back saccades with no intersaccadic interval. These are saccadic oscillations or intrusions, in this case, opsoclonus.
Mira.
Yes.
Hello.
Hi, sorry, do I have a question?
No. Please go on. Please go on.
Okay, got it. This is an example of abnormal gaze holding. So I'm asking her to simply look at a target in right lateral gaze and now look back to center. You see that in right gaze, there's right beating. When she looks back to center, there's left beating. Now she's looking to the left, there's left beating. She looks back to center, there's right beating. So this transition from gaze evoked in lateral gaze, then the patient comes back to center and the nystagmus changes direction, that's rebound nystagmus. That's always pathologic. That's how you know that a patient who has a little bit of jiggling and eccentric gaze has pathologic gaze-evoked nystagmus rather than normal physiologic endpoint nystagmus. What about saccades? So this is how you check them. I like to first check sort of lateral target or an eccentric target back to my nose. This is a great way to judge accuracy. If the patient's overshooting or undershooting your nose, it's very apparent. You want to make sure that you're checking horizontally and vertically in all planes, because burst neurons live in different parts of the brainstem, so that you can just affect the horizontal burst neurons or just affect the vertical burst neurons. What do you care about? You care about latency. So I say, look at the hammer. If it takes 10 seconds, that's an increased latency. That could be characteristic of certain neurodegenerative disorders, for instance. Accuracy, again, is the patient overshooting or undershooting? Conjugacy, are the eyes moving together? Is there an internuclear ophthalmoplegia? And finally, velocity, are these too slow? This is an example of a right Wallenberg, a right lateral medullary stroke. You can see when the patient looks to the right, he's overshooting the target, and he has to come back. When he's looking to the left, away from the side of the stroke, the saccades are hypometric. That is, that takes a couple small saccades to get there. So hypermetric toward the side of the lesion in a Wallenberg, hypometric away from the lesion, away from the usually a stroke. These are dysmetric saccades, and they can be highly localizing in this situation. When you're thinking about dysmetria, dysmetric saccades, you're thinking about the cerebellum, the vestigial nucleus, the dorsal vermis, and its connections via the inferior cerebellar peduncle in the lateral medulla, which is generally what's affected in Wallenberg that causes the dysmetric saccades in the first place. This is a patient I'm asking him to look up. And I'm sorry, it's right on the edge there. His upward saccades are a little bit slow, but his downward saccades are really, really slow, or perhaps even absent. So again, our knowledge of neuroanatomy will tell us where the problem is. The PPRF is responsible for the horizontal burst neurons, horizontal saccades. RIMLF is vertical and torsional saccades. This patient had a bilateral RIMLF lesions due to an artery of Percheron stroke. So if the saccades are slow, absent in all planes, think about something neurodegenerative. If the saccades are slow in a specific plane or absent in a specific plane, think about something structural. Think about an ischemic stroke, as in this case. What about smooth pursuit? So you don't want to go too fast. It's nice and smooth, nice and slow. And the patient's eye movements should be, as the name implies, nice and smooth. There shouldn't be any significant choppiness, or the patient shouldn't be substituting saccades for the smooth pursuit movements. So you want a small fixation target. You want to move it slowly. This is a nice example of normal smooth pursuit. This is abnormal smooth pursuit. This is a patient with an idiopathic cerebellar degeneration, and her head is fixed, and she's asked to move her eyes and follow a small target, and you can see how choppy it is. As soon as she gets too far to the left or to the right, you can see the gaze-evoked nystagmus as well. So you're really focused on smooth pursuit sort of in the center of the movement. And it's very choppy. Her pursuit was very impaired. So think about the basal ganglia, Parkinsonism, PSP in particular. Patients with Parkinson's disease can have a little bit of saccadic pursuit, but it tends not to be that significant like it is with PSP. Or also think about cerebellar disorders when it's symmetrically choppy and saccadic horizontally and vertically. What about the vestibulo-ocular reflex suppression? So this is a combined eye-head movement, just like this. It's nice if you have a swivel chair, which I'll show you an example on the next slide. You can simply have the patient look at their outstretched thumb and just move the chair, rotate the chair. And for this, again, her eyes are right on the target. This is an example of very normal VOR suppression. This is a combined eye-head movement. Pursuit and VOR suppression are almost always both saccadic or both normal. This is another way to assess the pursuit system and how well it's working.
Sorry to interrupt.
Dr. Dan Gold.
I think.
Yes.
Dr. Dan Gold, you just talk a little slowly so that your audio and video are not syncing.
Got it.
Yes.
Sorry.
Yeah, you be slow because the video streaming takes time.
Okay.
Your slide
Got it. Is it significant? Okay, got it.
It is significantly slow because please slow
Sorry
down.
about that.
Yeah,
Are the videos still look pretty smooth?
You are in the next while you're talking. Your video comes a little later.
Got it.
The video is working. The video is working fine, but there is a lag. So if you go a bit slowly, it should.
You talk slowly. It'll be all
okay. Will do. All right.
Yep.
Okay. So so this is an abnormal VOR suppression. abnormal VOR suppression. So in this situation, the patient's in a swivel chair. She's looking at her outstretched thumb, and I'm simply moving the chair. And you can see how saccadic these movements are. They're very choppy, just as choppy as the smooth pursuit was when I tested it. This is the same patient from 2 slides ago. So this suggests that, in fact, there is a VOR, there is a vestibulo-ocular reflex to suppress. So if the smooth pursuit looks very saccadic, very choppy, and the VOR suppression looks a lot better, that implies that there's no VOR to suppress and that the patient probably has significant vestibular loss. So again, if the pursuit is choppy, VOR suppression should be just as choppy unless there's no VOR to suppress. This is an example of asymmetric pursuit and vestibulo-ocular reflex suppression. So in the last example, a patient with a cerebellar neurodegenerative process that was idiopathic, pursuit and VOR suppression were very choppy everywhere. In this situation, his pursuit is really choppy to the left. Pursuit to the right looks good. And VOR suppression is very choppy to the left, but not to the right. So to the left, saccadic. To the right, normal. To the left, saccadic. To the right, normal. So this asymmetry implies that the lesion is going to be on the same side as the pursuit and vestibulo-ocular reflex suppression problem. So this was a pursuit and VOR suppression problem to the left side. And in fact, this patient had a chronic stroke that involved the left hemisphere, the ipsilateral hemisphere. So again, the take-home point is that if it's asymmetric laterally, the lesion is going to be ipsilateral. What about convergence? So this is how we test it. We want a small target. The near point of convergence should be about or greater than 10 centimeters. That is the point at which one eye will drift out and the patient will see 2. Should be less than 10 centimeters, not more than 10 centimeters. You want a small fixation target. This is an example of normal convergence with a near point of convergence that is less than 10 centimeters. This is a patient with convergence insufficiency. At distance, there's not much misalignment. At near, there's a very large exotropia. So the one eye comes in, one eye comes in. Every time an eye is covered, it has to come in to take up fixation. This patient has a large exotropia at near. She has horizontal binocular diplopia at near, and she just can't bring her eyes together. Her near point of convergence is greater than 20 centimeters, where I said less than 10 centimeters is the norm. So this patient also has saccadic intrusions. This patient has square wave jerks. And in fact, she has progressive supranuclear palsy or PSP. Convergence problems are very common with Parkinson's disease, with other types of Parkinsonism like PSP. And again, these saccadic intrusions, these square wave jerks are also quite common in PSP. If you're thinking about convergence insufficiency, you're thinking about sometimes neurodegenerative problems like Parkinsonism. You're thinking about head trauma. It can occur with normal aging as well. And the most common symptom is that the patient will experience horizontal diplopia at near. This is a patient who's looking at a near target and has upbeat nystagmus. Now he's looking at distance, and now it's downbeat nystagmus. Now he's looking at a near target, and it's upbeating again. Now he's looking at a distant target, and it's downbeating again. So it transitions depending on his vergence at that time. So convergence causes an upbeat, and diverging the eyes looking at a distant target causes a downbeat. So an important point here is that convergence, in somebody who has a little bit of gaze evoked, you might not see any spontaneous nystagmus. Convergence might provoke downbeat nystagmus in that particular patient. If the patient already has downbeat spontaneous nystagmus, it is likely to increase the amount of downbeat. In some cases, it can even cause the nystagmus, like in this case, to transition. The most common circumstance, or the one that you should know about, is a patient presenting to the emergency department with Wernicke's encephalopathy. As I showed you, spontaneous upbeat nystagmus.
Dan,
yes?
I think because the Zoom is being used all over the world excessively, there is a delay in the Zoom itself. So what is happening is, just now we are seeing VOR suppression, while actually you're talking about the convergence. That part we have not yet seen. So,
so it hasn't even advanced to convergence?
Yes. No, it is still showing VOR suppression over here. So what I will do is, while you are showing it, I will also give a commentary as to what is going on, because what you will be telling now. So now what we are seeing, I will tell you what to tell. So now we are seeing VOR suppression. And
okay, so the lag is, I mean, we're talking about at least 60 seconds of lag for the
now
videos.
I'm seeing, yes, so now I'm seeing convergence. You are taking it near and close. Now we are seeing the convergence.
Okay, okay. So now this is a normal convergence?
Maybe I can tell you one idea. If you have another phone, you can log in as a delegate.
Okay.
On that, so you will see what is going on to what we are seeing.
Got it. Okay.
What is there on your screen? Maybe
that's a good idea.
That might help you to synchronize. This is something new. So
all right. Sorry.
I will explain the audience what is happening. So because of the extra sort of traffic jam in Zoom all over the world, there is a delay. We are seeing the videos very smoothly, but the audio comes earlier. So maybe just try with a phone what happens, and let us see. So otherwise, anyway, I will add what is going on. So now we are seeing the convergence part of it.
Okay.
And we are seeing the cover, uncover, convergence, insufficiency.
Got it. My apologies, everyone.
No, it's not your, we can't do anything about it. I think it's too many people using Zoom. Okay, now we are seeing cover, uncover for the convergence.
Okay, all right, so I am...
Can you log in with the phone? Have you seen, do you see what is happening?
Yes, I do.
Okay, so now we are seeing, and do you see the lag on the phone versus what is there on your laptop?
Okay, so now I'm looking at two screens. This is very confusing, but now I see where you are. Okay, so this is the patient with PSP, progressive supranuclear palsy. So you can see a couple things going on. One is that she's looking at a near target. Every time I uncover one eye, the eye is coming in. So this patient has a very large exotropia at near. This is me testing the near point of convergence. So a normal near point of convergence should be less than 10 centimeters or so. In this situation, she just really couldn't converge the eyes at all. So she was seeing horizontal diplopia well over 20 centimeters away from her, which is not normal. Additionally, she has these saccadic intrusions. So you could see This is a minutes long lag between the two.
Yes.
This is going to be very confusing.
Dan, you can use your laptop just to take the slide ahead, but don't look at your laptop screen. You'll get confused.
No, I know. I'm trying not to. The problem is I don't know when to advance it on my laptop if there's a couple minute delay. Okay, so she has convergence insufficiency. The other thing that she has are these saccadic intrusions. So you can see these little back and forth movements, and that's very typical of progressive supranuclear palsy. Patients with Parkinson's disease can have these little square wave jerks as well, but they tend to not be nearly as prominent as they are in PSP, for instance. So if somebody has poor convergence, you're thinking about Parkinsonism, you're thinking about head trauma. This can occur with just normal aging in a patient who has no other ocular motor abnormalities. But the most common symptom a patient will complain of is horizontal diplopia at near. Sometimes they don't complain of horizontal diplopia at near, but simply they find themselves or their loved one notices that they're constantly covering one eye when trying to read or squinting, for instance. All right, so now I have no control over what's happening in the Zoom webinar. I'm just hoping that the slide advances soon. Okay,
now we are seeing.
Got it. So this is a patient who has upbeat nystagmus at near when converging the eyes. And when I have the patient look at a distant target, now it's downbeating nystagmus.
Yes.
So it transitioned from upbeat.
Now we are talking what we are seeing. So now this is fine, Dan. We have to just go along as it is. Fine.
Okay, I'm just looking at my phone, but trying to advance the slides on my computer simultaneously. So, so this patient has vertical nystagmus that depends
Say yes when you see
on the
his fingers
distance of where the patient is. So again, vergence, convergence, near, upbeat, and distance is downbeat. So I would always have people test patients' vergence, test their convergence. If you have a patient who has some imbalance, who has a little bit of gaze-evoked nystagmus, for instance, and let's say they don't have spontaneous downbeat nystagmus, but if you have them converge, if you have them look at a small target that's close to their face, it's very common that you will provoke downbeat nystagmus in that patient. If the patient already has downbeat nystagmus, it's common that you will increase their downbeat. In some cases like this one, you can cause the vertical nystagmus to transition from upbeat to downbeat, for instance. A patient who comes into the emergency department with Wernicke's encephalopathy may have spontaneous upbeat nystagmus. If you have them converge, this can transition to downbeat nystagmus. This can be a clue that you're dealing with Wernicke's. This can be a clue that you need to administer intravenous thiamine immediately. Convergence will also damp congenital nystagmus. So if somebody has infantile or congenital nystagmus that they've had for their entire life, oftentimes it's going to damp if you have the patient look at near. And I think it's going for so long because this is when you pointed it out to me and I just stayed on the slide for a long time. Unfortunately, I don't have any control over advancing it at this point.
It's going on fine. Don't worry. You can talk about it while it advances. So
okay. So for fixation and gaze holding, saccade, smooth pursuit, VOR suppression, is there anything that I need to clarify, or do I need to clarify everything because nothing could be seen? while I'm waiting for this.
So this point about Wernicke's using convergence, can you just explain that again?
So if a patient comes in with spontaneous upbeat nystagmus, another common ocular motor finding in Wernicke's, or a few common findings, include horizontal gaze-evoked nystagmus. Oh, it just advanced to the optokinetic. Ugh. So I don't have control over. So a patient with spontaneous upbeat with Wernicke's, their nystagmus can transition to downbeat when they're looking at something close to them, when they're converging the eyes, when they're looking at a near target. Other features that are common, oftentimes related to the medial vestibular nucleus and or the lateral vestibular nucleus, which have a role in the translational vestibulo-ocular reflex, the TVOR. The TVOR is what the sort of the otoliths, right? So the utricle, the saccule, these are the linear acceleration detectors. These subserve the TVOR, the translational VOR. These inputs for the TVOR are modulated by the nodulus. There's a lot of interconnectivity between the MVN, LVN, and the nodulus. And because the utricles, because the TVOR depends on orbital position and vergence, and because in Wernicke's encephalopathy, the MVN is affected, that's thought to be the reason for why patients have this transition from upbeat to downbeat, for instance. And I'm sorry, I'm very distracted by looking at two screens right now, so it's just not advancing. Maybe, maybe Sudhir, we should figure out offline how we might do this again. I definitely don't think we should go on and do the vestibular part, because it's just going to be too confusing.
Yes. I think we'll go slow. Just do the first half of it, and let us hope the Zoom people solve this problem in the meantime, because this must be happening to everybody. So
right. Okay. So what would you like me to do? This won't even advance to optokinetic. I can just close the presentation and open it again at optokinetic. Maybe try one time.
Okay, let's do that. Let's see.
Okay.
Okay, now it has started. The optokinetic has started.
Okay, so then it just went on to the next. Let me just see if I can.
We are seeing the optokinetic now.
I know. I started to explain it, the slide before this, but then it went away. So in this situation, the patient has asymmetric optokinetic nystagmus. This patient has a left homonymous hemianopia.
It is going very random.
Yeah, all right. I'm going to stop share and see what happens. Okay, so it stopped the share immediately. And I'm just going to start from the optokinetic slide here.
Okay, let's try. Dan, let us see if it works. If not, then I think we shall postpone this talk. We will just work around this again, because your talk is absolutely fabulous and I don't want it to be spoiled because of this lag. So we will work out what is to be done.
Right. So now was there less of a lag at the very beginning? So now I can't even share my screen.
Yeah, the screen is not even getting shared. We can,
Yeah.
I mean, last 30 seconds we are seeing you have started sharing, but it's shared.
Right.
So,
okay. Well, should I just take some questions about what I covered, and then we can figure it out offline?
Let us take some questions and answers, and
okay.
We'll have the video and the slides later. So I think we can stop sharing the screen.
Oh, yes, so now we have the speaker's view.
Yeah. Okay, I'm not seeing Dan still. Lakshmi, are you there?
I'm here.
Yeah. We are not seeing Dan, his video still. Yeah. What question do you, I think we'll have, this is the first time this is happening. So it is really a beautiful talk. Like I know I've seen the original talk, and what we shall do is we'll
take a few audience questions, which is there.
So audience can go ahead and start asking questions. We'll just have questions and answers, and he could show how he examines and things like that. So I think let us ask him. I myself would like to understand how convergence makes the nystagmus, which was upbeat, to turn into downbeating. Let us understand that part one, because that's an important clue. So I think we are waiting for Dan to come, his video to come online. Let me see. Yeah, he's joined.
Can you hear me?
Yeah, we can
Yeah,
hear. We can hear you.
Okay.
We are yet to see you, but we are hearing you. So Dan, what we thought is, let us just have some question and answers. Lakshmi, can you change the way you are sitting so that there's no light behind you?
Sure.
Yeah. That light behind has to be switched.
Yeah, I'll.
So Dan, you could explain again about how vertical nystagmus, which was upbeating, changes to downbeating because of convergence. So I think that is one important clinical clue. And let us understand again how and what you do to do, how it happens, why it happens.
Right. So it's not entirely clear or very well understood. So the angular, the rotational VOR, vestibular ocular reflex, which is subserved by the semicircular canal. So I'm moving my head back and forth. This is the rotational VOR. That's the job of the semicircular canals. There's also the translational VOR, where I'm using the otoliths, the utricle and the saccule, for instance. And I'm translating the head. I'm using the linear acceleration detectors for that. In order for the TVOR, the translational VOR, to generate the appropriate eye movements, you have to take into account, or they have to take into account, the orbital position and the vergence angle, so convergence, divergence, what the eye position is. It's thought that brainstem structures that are responsible for helping to process this otolithic information, the utricle inputs, the saccule inputs, include the medial and the inferior vestibular nuclei, which are both in the medulla, which have projections to the cerebellar nodulus, which also has a role in modulating the TVOR. So the MVN, the medial vestibular nucleus, is very much involved in Wernicke's encephalopathy. We know that because patients with Wernicke's encephalopathy can have different manifestations of the MVN being affected. One is that the MVN NPH complex is responsible for horizontal gaze holding. So if my MVN NPH complex doesn't work, when I look to the right, my eyes will drift back to center, and that will generate the slow phase and then the fast phase. That's gaze-evoked nystagmus. Gaze-evoked nystagmus is extremely common in Wernicke's encephalopathy. Also, the horizontal semicircular canal afferents immediately go to the medial vestibular nucleus as well. In Wernicke's encephalopathy, it's very common that the vestibulo-ocular reflex, the horizontal VOR, is affected, so that patients can have a horizontal abnormal VOR or head impulse test, and those pathways can be spared vertically. So we know that the MVN is affected in Wernicke's. So if the MVN has a role to play in the translational VOR and the TVOR, and the MVN is connected to the nodulus, then it makes sense that you might have, for those reasons, because the otolithic inputs just can't be processed in the way that they normally are, you might have a transition in your vertical nystagmus.
Okay.
We don't know for sure if that's why, but that's a theory.
Okay, then I think we need to go back a little. Many people do not know what is VOR gain and what is VOR suppression. So first of all, let us begin with what is VOR. Then maybe you can explain what is VOR gain. What do you mean by VOR gain and what do you mean by VOR suppression?
Right. So the vestibulo-ocular reflex, the VOR, so this is me moving my head and being able to keep my eyes steady on the target. The VOR, the role of the VOR, it's one of the classes of eye movements that allows your vision to be stable when your head's in motion. So I can walk down the street, and because my VOR works horizontally and vertically, I can read in front of me the street sign clearly. If you have no VOR, your eyes will move with each head movement so that each footstep, the eyes are bouncing, the world is bouncing. That causes head movement induced oscillopsia. So that's the role of the vestibulo-ocular reflex. So if my gain is off, my VOR gain is off, and all of this would have been covered in the next talk on the vestibular exam. But if the gain is off, if I have all of the sudden on the right side, I have an acute vestibular neuritis, I present to the emergency department with the acute vestibular syndrome, I have acute onset prolonged vertigo, and I have spontaneous nystagmus that's left beating given my right vestibular neuritis. If I do a head impulse, or if I move my head quickly to the right, to the impaired side, the side of the acute vestibular neuritis, my eyes will go with my head for a split second, and then my brain will realize that I've lost the visual target, that the visual target has slipped off of my fovea, and I will have to generate a refixation movement. That is a decreased gain. We can measure this at the bedside. We know that somebody has a hypoactive VOR, again, right-sided vestibular neuritis, move the head quickly to the right, the eyes go with the head to the right, then there's a refixation movement back to the visual fixation point. That's an abnormal head impulse on the right. That suggests that there's a hypoactive VOR on the right side. We can measure that, I'm sorry, we can measure that with the video head impulse test as well. The video head impulse test measures the ratio of the eye movement velocity, which is the output, to the head movement velocity. So if I move my head quickly in any direction, the eye movement velocity should match the head movement velocity, and therefore the gain should be 1. But if I move the head quickly to the side of an acute vestibular neuritis, the eye movement velocity will not match the head movement velocity, and therefore the gain will be much lower. At the bedside, we see the corrective saccade. On the video head impulse, we can see the corrective saccades, but we can also calculate the gains, which can tell us that there's 50% vestibular function on the right side, or 25%, or whatever. So that is the VOR, that is the VOR gain. I haven't gotten to the VOR suppression yet. Would you like me to, do you want to clarify something?
Yes, I'll just rephrase it for some of them. So when you are looking at an object, like Dan is saying, and you move your head, if I move my head to the right 30 degrees, and if I'm supposed to keep looking at my finger, I'm looking at my finger and I move my head to 30 degrees to the right. If my VOR is normal, then my eyes immediately, even before I know it and before I do it voluntarily, automatically the eyes move 30 degrees to the left, so that my eye still keeps looking at the target. If my VOR gain is 1, then head moves 30, eyes will also move 30. But if the VOR gain is, let's say, 50%, then my eyes will move only 15 degrees. And so the remaining part, like Dan told you, you have to make a saccade so that you still keep looking at the target. So that is VOR gain. This is instantaneous. It is within microseconds that the eyes move when you move your head. And the main function of the vestibular system is to keep your eyes on the target. Now he will explain what is VOR suppression.
Right. So smooth pursuit. So you're taking a slowly moving target, a small target. This is smooth pursuit. It shouldn't be choppy. It shouldn't be saccadic. When the smooth pursuit gain is too low, then people will compensate with saccades so it can look saccadic. That's what gives it the choppy appearance. Another way to evaluate the smooth pursuit system is by assessing vestibulo-ocular reflex suppression, the ability to suppress the VOR. So if I move my head in any direction, if I move my head to the left, I'm firing the left horizontal canal, which drives my eyes in the opposite direction. If I move my head to the right, then I'm firing the horizontal canal afferents on the right side, which is moving my eyes to the opposite direction. So this is the VOR working. But there are circumstances in normal life where you need to turn off the vestibulo-ocular reflex. Think about yourself riding on a bus that's making a turn. You want to keep reading whatever it is that you're looking at, the book, while the bus is turning. You need to suppress or turn off that vestibulo-ocular reflex. So because it is necessary under normal circumstances to turn off the VOR, you don't always need it. Sometimes the VOR would actually take your eyes off of the fixation target, whatever it is that you're trying to look at. You should be able to also suppress the VOR. So the way to test for VOR suppression or cancellation, this is a combined eye-head movement. So I'm looking right at my thumb, I'm moving my head and my eyes together, and I'm able to visualize that target. It's like another way to test.
Chair. Like you said, when you are examining a patient, if you have a swivel chair, then it is easy to do this, what you did.
Right. The swivel chair is very nice. You just have the patient hold their thumb out and you just move the chair. They don't have to do anything. The instructions that you give the patient are to look at their thumbnail or to look at whatever it is you're having them look at, and you swivel the chair. It's a very nice way to evaluate for vestibulo-ocular reflex suppression. So VOR suppression and pursuit are always going to be the same. So I showed you a couple of examples of very choppy or saccadic impaired smooth pursuit. If the patient's very choppy smooth pursuit looks exactly like the patient's very choppy VOR suppression, then that tells you it's another reflection of that impairment of the pursuit system, but it also tells you that there is a VOR to suppress. If you see a patient who has very saccadic smooth pursuit, but then you do vestibulo-ocular reflex suppression and the VOR suppression looks really normal, that tells you, without even doing any tests to evaluate the vestibulo-ocular reflex, without even doing head impulse, that that patient has bilateral vestibular loss. A common situation where you're going to have really choppy pursuit, perhaps due to cerebellar degeneration, let's say, and a loss of the vestibulo-ocular reflex, loss of the VOR, bilateral vestibulopathy is a condition called CANVAS, so cerebellar ataxia, neuropathy, and vestibular areflexia syndrome. So if you, again, smooth pursuit, very choppy, very saccadic, VOR suppression looks much better. That dissociation tells you that there's probably a VOR problem without you even having to do any VOR or before you've done the head impulse, for instance. So that's the importance of checking both pursuit and VOR suppression. Also, in patients who have really saccadic or choppy smooth pursuit, oftentimes they have a cerebellopathy, they have a neurodegenerative problem, they have a spinocerebellar ataxia. They may also commonly have spontaneous nystagmus. So sometimes it can be tough to know, is that smooth pursuit choppy or saccadic or impaired, or is that just the fast phase of the vertical nystagmus or the spontaneous nystagmus that I'm seeing? You kind of get by that problem. You bypass that problem a little bit by also checking vestibulo-ocular reflex suppression, because you're just looking at, in that situation, any horizontal movements, and it becomes more apparent that you have a pursuit problem in addition to a spontaneous nystagmus problem.
Okay, so I will, again, I will simplify it, one part of it, that when you are doing the VOR suppression and you hold, the patient is asked to hold his hands out and then move like this, you should not see any horizontal movement. So no nystagmus. If you see nystagmus, means the VOR suppression is abnormal. And Lakshmi, you want to ask some of the questions which are there in the question answer? You can read the question answer thing. I can't hear Lakshmi. Okay, so I think...
One minute. Can you hear me now?
Yes.
Yeah. Deepak Menon has asked, how could one assess intersaccadic interval and how to differentiate square wave jerks and macrosaccadic oscillation?
Right. So most of the time, and I really also like to use the ophthalmoscope. So just looking at the fundus gives you so much magnification. If there are just little saccadic intrusions to the naked eye, they may not look like much, but when you're using the ophthalmoscope, when you're looking at the fundus, that magnification can really be helpful to try to tease out what is this? What is the waveform? What is going on here? Square waves are very common. Again, square waves are called square waves because on the eye movement recordings, there's just these little movements that bring the eyes away from fixation, and they look like little squares, the waveforms do. So you can also have macro square waves. So if the amplitude of those movements is larger than a normal square wave, for instance, then they might be classified as a macro square wave jerk. Again, this implies that there's some problem with the fixation pathways. That doesn't mean it doesn't have a really good localizing value, but the square waves can be seen just as people age normally to some degree. But patients with Parkinsonism, patients with cerebellopathies tend to have more of these saccadic intrusions than others. So macro
when you're
good.
Looking at the fundoscope, you'll see the disc moving.
Correct. Also remember, when you're looking with a direct ophthalmoscope, if you see what looks like right beating nystagmus, it's actually left beating nystagmus. If you see what looks like up beating nystagmus, it's actually down beating nystagmus. The reason is that you're looking posterior to the axis of rotation for horizontal and for vertical eye movements. So everything is reversed. But if the patient has torsional nystagmus with the top poles beating towards the right ear, and that's what it looks like with the ophthalmoscope, that's what it is, because that axis of rotation is different than it is for vertical and for horizontal movements. But the ophthalmoscope can be a really nice tool. For patients who have macrosaccadic oscillations, usually this is more of sort of a dysmetria kind of problem. This is a cerebellar problem. This is, they're constantly trying to bring the eyes to fixation, but they're constantly going too far. And think about somebody putting on a putting green, playing golf. they're going too far this way. Now they're trying to come back, and then they went too far, and then they went too far, and you eventually get there. So it's kind of like that. So every movement results in a dysmetric movement, a dysmetric saccade. The macrosaccadic oscillations are usually cerebellar in origin and related to this dysmetria.
There's one more question. What is the difference between optokinetic nystagmus and VOR suppression? So what is the difference between the smooth pursuit pathway and OKN?
Right. So the smooth pursuit pathway, so there's a lot of overlap as well. But the optokinetic pathway, and I had a really nice video example, which unfortunately didn't play, of a patient who has a left homonymous hemianopia due to a right parieto-occipital lesion. He had a glioblastoma, so left homonymous hemianopia, right-sided lesion. He has completely intact optokinetic nystagmus to the left, but as soon as the optokinetic tape, the optokinetic flag is brought toward the side of the lesion, ipsilesional, he has no optokinetic response. So the origins of the optokinetic nystagmus pathways sort of live in the parietal lobe. That's one way that you can differentiate if somebody has a homonymous visual field defect, whether it's occipital, whether it's parietal. If you have lost the optokinetic response, you can't generate optokinetic nystagmus. That tells you that the problem is in the parietal lobe as opposed to the occipital lobe, although both may be impaired as well, as it was in that case. So the optokinetic pathways, the job of the optokinetic pathway is mainly to supplement the VOR response so that if there's prolonged movements, prolonged rotation, for instance, the optokinetic response can help to prolong that. It optimizes the way that the vestibulo-ocular reflex functions, but the pathways are very diffuse and very complicated.
Okay, Lakshmi.
Sir, what is the mechanism of lateral pulsion in Wallenberg? Somebody has asked the question. The question is asked by some anonymous person.
Anonymous person, got it. So this has to do, and David Z talked about this, I guess last week as well, but these saccade pathways. So let's say you have a left Wallenberg, a left lateral medullary stroke. So those pathways are going to decussate. They're going to travel up the inferior cerebellar peduncle to the Purkinje cells of the dorsal vermis. They're going to go from the dorsal vermis to the vestigial nucleus. They're going to cross over to the pons, to the PPRF, to the sixth nucleus. These very complicated pathways are in equipoise. Both sides are nice and balanced. As soon as you have a lesion to one side, there's sort of a directional bias, a directional preponderance for the eyes to go in one direction versus the other. That imbalance in these saccade pathways that go from the lateral medulla, the inferior, through the inferior cerebellar peduncle, to the cerebellum, to the dorsal vermis, to the vestigial nucleus, back to the pons. This pathway, when affected, can cause a couple things. One, in the case of a left Wallenberg or a left lateral medullary stroke, the patient, when asked to move the eyes quickly to perform a saccade, will overshoot the target toward the side of the lesion, left Wallenberg. There will be left hypermetria. And when asked to make a saccade away from the target, there will be right hypometria. So it'll take a couple little saccades to get to the target opposite the side of the Wallenberg. The other very common occurrence, again, a consequence of this imbalance in these saccade pathways, is that if you ask a patient who has a left Wallenberg to close the eyes will drift toward the side of the lesion, again, because of the imbalance in the pathways, and then they open their eyes and the eyes come back. So ask the patient to close the eyes. Under closed lids, they drift in the direction that they want to go, which is toward the side of the lesion, toward the side of the Wallenberg. You ask the patient to open the eyes, and then they come back. That's ocular lateral pulsion. If you have a left Wallenberg, there's also body lateral pulsion. So the patient will veer, will fall towards the left side. You may see left-sided dysmetria, limb ataxia on the left side. The eyes also go to the left side. That's called ipsipulsion because the eyes are deviating toward the side of the lesion, or ocular lateral pulsion.
There's one interesting question. How do you get VOR suppression only on one side, and what conditions will cause VOR suppression towards the right but not towards the left?
Right. So I showed one example, which I have no idea if anybody could see, but one example, a patient who has a hemispheric stroke, for instance, and you said right side. So if you have a hemispheric stroke, big MCA stroke on the right side, you may have choppy pursuit to the right, but not to the left. You may also have choppy vestibulo-ocular reflex suppression to the right, but not to the left. That's one situation. Another situation where you can have really asymmetric VOR suppression would be a patient who has saccadic, very saccadic or choppy smooth pursuit. And with vestibulo-ocular reflex suppression, like I said, you would expect that VOR suppression should be as choppy as pursuit unless there's no VOR to suppress. So if you had a profound loss of vestibular function on one side, but not the other, you might see symmetrically choppy pursuit to the left and to the right, but then you might see significant VOR asymmetry, vestibulo-ocular reflex suppression asymmetry, where it's very choppy in one direction and it looks really smooth in the opposite direction. For instance, here, if it's choppy to the left and normal to the right, that would imply that there's a hypoactivity, a deficient right vestibulo-ocular reflex suppression. Or I'm sorry, a right hypofunction of the VOR. So the patient had an old vestibular neuritis on the right side, for instance. Then they had a new acquired cerebellar neurodegenerative process that's causing impairment of smooth pursuit.
There is one more question. It says, how do you examine a torsional eye movement? What is the best way to examine a torsional eye movement?
Torsional eye movements. Right. So in some cases, it can be really apparent. So torsional eye movements, you should name it by the top pole is beating toward which ear. So in this case, the top poles of my eyes are beating towards the right ear. That's how you should name it. You should avoid clockwise, counterclockwise. That can be very confusing. If you're looking with the ophthalmoscope at the optic nerve, if you're looking at the posterior pole of the eye, that's where there's the least amount of movement. So if you don't look closely with some magnification like Frenzel goggles can be very helpful trying to pick a conjunctival blood vessel to focus on so that you can see if the eye is moving in this direction, if there's a torsional movement. The ophthalmoscope, because you're looking at the posterior pole isn't moving much if there's a lot of torsion, can be a little bit misleading. Having a pair of Frenzel goggles or video Frenzel goggles are these +20, +30 diopter lenses that give you a lot of magnification. They allow the patient, or they fog the patient's vision, remove visual fixation so that you can accentuate vestibular nystagmus, or even if you don't accentuate vestibular nystagmus, the eyes are just very big. There's illumination as well. So Frenzel goggles would be sort of the easiest way to assess for torsion if you have that tool.
Yes. Dr. Sudhir and Dr. Don, and we would love to have your second part of the lecture. I think Dr. Sudhir would inform you, because you can see there are about 590 neurologists across the country who are waiting to listen to you.
Yes.
It's very unfortunate that we were not able to sync. So we will fix up that. And you would like to take some more questions, Dr. Sudhir, or what is it?
We can, maybe another 10 minutes, Dan, we can have some questions. I'll just check some of them. So Somebody wants to know, can you have slow saccades but still have nystagmus?
Yes, you can. If you have, so it depends on why you have the slow saccade. So if you have a pure PPRF problem or a pure rostrointerstitial medial longitudinal vesiculus problem, for instance, if we talk about an RIMLF, a pure RIMLF syndrome, I showed one patient here. I have no idea if you could see it or not, but this patient had an artery percheron stroke that infarcted both of the RIMLFs, right and left side, and he couldn't generate downward saccades at all. His upward saccades were very slow as well. So a feature of a unilateral RIMLF syndrome is that the patient can have spontaneous torsional nystagmus, because again, the RIMLF is responsible for vertical saccades, but also torsional saccades. So in that situation, you can absolutely have spontaneous nystagmus and very slow vertical saccades. That's one situation. If you have slow saccades from a PPRF lesion, likewise, you can have different, let's say somebody had a cavernoma in the pons that hemorrhaged, and 3 months later, they started to develop a vertical pendular nystagmus. You looked at the back of the throat and they have a palatal tremor. This is oculopalatal tremor. If you have a dorsal pontine hemorrhage, then you can have horizontal gaze palsy, for instance. So the patient can't look to the right, can't look to the left, but you can still develop a vertical pendular nystagmus consistent with an oculopalatal tremor, given the proximity of the central tegmental tract as it courses through the dorsal pons. But if you have slow saccades because you have really severe ophthalmoplegia, for whatever reason, from myasthenia gravis, from thyroid eye disease, from whatever, then you may have very little or no nystagmus. If you had myasthenia gravis and you can't move your eyes at all, and for some reason now you have downbeat nystagmus because you're toxic on your phenytoin, then you might not have downbeat for that reason. So it depends on why the saccades are slow and to what degree.
Okay, so Dan, we will test again, and I will write to the Zoom authorities and find out what they're going to do about this lag. And we'll reschedule this because I have seen your talk and it is absolutely wonderful, and people we should not miss this because of this technical glitch.
Yeah, you could see there's so many people are missing this and they're requesting for a rescheduling of the talk. Dan, and we would love to have you again. Dr. Sudhir would organize that, and it was really wonderful to have you amidst us, and we're looking for, I think we should fix it when the US sleeps. That's the best time because now it is 10:35 in New York. So the traffic is so much that is one of the causes. So I think we should disturb you on a late night when the US sleeps. We should be able to sync better.
Maybe.
Got it.
We'll check out. We'll see what.
How best we can have you.
We will check it out. Thank you, Dan.
All right. Thank you. Sorry.
Thank you. Stay safe. Stay safe and
take care.
Thank you.
You too.
Thank you.
Bye.